Dental public health, DPH, is a non-clinical specialty of dentistry that deals with the prevention of oral disease and promotion of oral health. Dental public health is involved in the assessment of key dental health needs and coming up with effective solutions to improve the dental health of populations rather than individuals. Prevention is becoming increasingly important. Dental-related diseases are largely preventable and there is a growing burden on healthcare systems for cure. Dental public health looks beyond the role of a dental practitioner in treating dental disease, and seeks to reduce demand on healthcare systems by redirection of resources to priority areas. Countries around the world all face similar issues in relation to dental disease. Implementation of policies and principles vary due to available of resources. Similar to public health, an understanding of the many factors that influence health will assist the implementation of effective strategies. Public health dentistry is practiced generally through government-sponsored programs, which are for the most part directed toward public school children in the belief that their education in oral hygiene is the best way to reach the general public. The pattern for such programs in the past was a dental practitioner's annual visit to a school to lecture and to demonstrate proper toothbrushing techniques. The 1970s saw the emergence of a more elaborate program that included a week of one-hour sessions of instruction, demonstration, and questions and answers, conducted by a dentist and a dental assistant and aided by a teacher who had previously been given several hours of instruction. Use was also made of televised dental health education programs, which parents were encouraged to observe. Background: there seems to be a lot more that can be done to help individuals prevent tooth decay and gum disease based on what is already known. Even with fluoridation and oral hygiene, tooth decay is still the most common diet-related disease affecting many people. Tooth decay has the economic impact of heart disease, obesity, and diabetes. Dental decay is however easily prevented by reducing acid demineralization caused by the remaining dental plaque left on teeth after brushing. Risk factors for tooth decay include physical, biological, environmental, behavioral, and lifestyle-related factors such as high numbers of cariogenic bacteria, inadequate salivary flow, insufficient fluoride exposure, poor oral hygiene, inappropriate methods of feeding infants, and poverty. Neutralizing acids after eating and at least twice a day brushing with fluoridated toothpaste will assist prevention. Cavities can develop on any surface of a tooth, but are most common inside the pits and fissures in grooves on chewing surfaces. This is where the toothbrush bristles and fluoride toothpaste cannot reach effectively. Gum diseases, gingivitis and periodontitis, are caused by certain types of bacteria that accumulate in remaining dental plaque. The extent of gum disease depends a lot on host susceptibility. Daily brushing must include brushing of both the teeth and gums. Effective brushing itself will prevent progression of both dental decay and gum diseases. Neutralizing acids after eating and at least twice a day brushing with fluoridated toothpaste will assist preventing dental decay. Stimulating saliva flow assists in the remineralization process of teeth. This can be done by chewing sugar-free gum. Using an interdental device once daily will assist prevention of gum diseases. Fissure sealants applied over the chewing surfaces of teeth block plaque from being trapped inside pits and fissures. The sealants make brushing more effective and prevent acid demineralization and tooth decay. A diet low in fermentable carbohydrates will reduce the buildup of plaque on teeth. Current practice. Dental public health competencies. The American Board of Dental Public Health, ABF, have devised a list of competencies for dental public health specialists to follow. Dental public health specialists are a select group of certified dentists. The 10 competencies allow for growth and learning of individuals and set expectations for the future. An advantage of the design is that they are implementable on a global level. The list is updated periodically. Scope of the dental public health. Major areas of dental public health activity include Oral Health Surveillance. National Oral Health Surveillance System, NOS, is designed to monitor the effects of oral disease on the population, as well as monitor how the oral care is delivered. Additionally, the status of water fluoridation on both a state and a national level is continually supervised. Assessing the evidence on oral health and dental interventions, programs, and services. Policy and strategy development and implementation. Oral health improvement. Health and public protection. Developing and monitoring quality dental services. Dental public health intelligence. Academic dental public health. Role within health services. Principles of dental public health. Dental health is concerned with promoting health of an entire population and focuses on an action at a community level, rather than at an individual clinical approach. Dental public health is a broad subject that seeks to expand the range of factors that influences people's oral health and the most effective means of preventing and treating these oral health problems. Criteria to determine a public health problem. To allow a health problem to be properly managed, it is important that there is a set of rules or criteria to follow which determines what is defined as a public health problem and what is the best way to manage health problems in communities. Approaches to prevention. Fluoridation of drinking water. Water fluoridation is the implementation of artificial fluoride in public water supplies with the intentions to halt the progression of dental diseases. Fluoride has the ability to interfere with the demineralization and remineralization process that occurs on the tooth surface and improves the mineral intake when the pH level may reduce below the neutral pH level. This achievement was implemented through the public health development in the 19th, 20th century and led into the 21st century. Research into the effects of fluoride on teeth began due to the concern about the presence of dental fluorosis. Many clinical case trials occurred in the beginning of the 20th century. However, the very first clinical trial to have occurred dates back to the 19th century when Denninger conducted a trial prescribing children and pregnant women with calcium fluoride. From this trial it was recognized fluoride's significance on tooth tissue, and from this point, many clinical trials were conducted following these studies. The recognition of the positive outcome on dental tissues became clear and projects in water fluoridation became of significant importance. The development of artificial water fluoridation began in 1945 in the Grand Rapids, Michigan, followed by Newburgh, New York and Evanston, Illinois. In 1955 three towns, Watford, Kilmarnock and Anglesey, trialed the water fluoridation implementation scheme. In 1960 the Republic of Ireland implemented all public water supplies with artificial fluoridated water, and 4 years later extending this into the main cities of Dublin and Cork. Currently, 40 countries have fluoridated water schemes implemented. Fluoride is still yet to be completely implemented across the full population. However, progress is slowly improving and access is becoming more common. Career opportunities focusing on prevention. Prevention methods such as oral health promotion began with the education of clinicians and the population in the health promotion strategies. Since the mid-19th century, oral health practice has revolved more around prevention and education rather than treatment of disease. This education can be focused towards dental practitioners and to the wider population who may be interested. There has been a change in focus in the education of developing clinicians all over the world. The first dental school was developed in 1828 and was followed by an ever-growing field of practice. The dental practice began with its main focus on the treatment of oral disease and branched into a wide scope of practice with many dental occupations involved. The most common form of dental clinicians are either general dentists, oral health therapists, dental therapists, and dental hygienist. When desired, some of these clinicians may seek further experience in projects that may assist the dental public system in bringing further awareness to prevention of dental diseases. Oral health prevention is the current form of practice of many clinicians. as education in oral care to the population is now believed to be the superior solution rather than the treatment of disease. Dental university education now develops clinicians to focus on the education of patients, education of the community and a wider population using different approaches. Approaches to promotion. Oral health promotion outlines the strategies for improving and educating the general public about how they can better improve and maintain their current oral health. Oral health promotion is part of both government and private incentives to create a healthier and better educated generation of individuals. There are three important ways in achieving oral health promotion, which is done by addressing the determinants of oral health, community participation, and implementing a strategy approach that involves a range of complementary actions. Determinants of oral health. Oral health promotion focuses on individual behavior, the socio-economic status and environmental factors. Underlying determinants that can also impact oral health, including non-milk extrinsic sugars consumption, alcohol consumption, and smoking behavior. The ability to remove dental plaque, exposure to fluoride and access to quality dental care can affect the ways the aforementioned underlying factors are and can be modified to the needs of the individual to obtain optimum oral health. Ways in which oral health promotion can minimize the effects of these determinants. Promoting healthy eating. Teaching effective oral hygiene practices. Promoting the use of topical fluoride for preventing and control of dental caries. Facilitating early access to preventative dental services. It is also important to note that these factors are also influenced by socio-political considerations that are outside the control of most individuals. Community participation is a key factor in oral health promotion. Intersectoral collaboration is where relevant agencies and sectors are involved in partnership to identify key oral health issues and to implement new methods to improve oral health. The World Health Organization has agreed on a health promotion approach as the foundation for oral health improvement strategies and policies for the population. Oral health promotion is based on the principles of the framework, Ottawa Charter. There are 5 areas of action outlined to achieve oral health promotion: building health public policy, creating supportive environment, strengthening community action, developing personal skills, reorienting healthcare services. International examples. Australia. Child Dental Benefits Schedule, CDBS. A government-funded program which provides assistance for basic dental services for children aged to 17 years. Services provided include examinations, dental x-rays, cleaning, fissure sealants, fillings, extractions and root canals. The CDBS is means tested. Those who qualify are eligible to $1,000 of the aforementioned treatments over a 2-year period. To find out if a child is eligible, families can contact the Department of Human Services. National Partnership Agreement on Adult Public Dental Services. As part of the National Partnership Agreement on Adult Public Dental Services, between 2015-2016 $155 million was provided to service around 178,000 adult public patients. On December 15, 2016, a further $320 million has been provided by the Australian government. The funding will assist in providing dental services to public adult patients for the next 3 years. Public dental services. For information and eligibility criteria on each state or territory's public dental services, visit your state health department website. Act Health. Northern Territory, Department of Health. Queensland, Queensland. South Australia, South Australian Dental Service. Tasmania, Oral Health Services Tasmania. Victoria, Department of Health. Western Australia, Dental Health Service. United Kingdom. National Health Service, NHS, Dentistry. National Health Service, NHS, is the name of the Public Health Services of England, Scotland, and Wales and is directly funded from taxation. The dentistry services are available to all, regardless of wealth. In order to find a NHS dentist, search NHS dentist near you. Some clinics may not have the capacity to take on new patients, so waiting lists may occur. Availability of treatment. All treatment deemed necessary to maintain optimal oral health will be provided by the dentist, however not all treatments will be funded by the dentistry NHS and will incur private fees. Fees. Dentistry performed under the dentistry NHS will involve fees, however are heavily subsidized by the government. Below is some information which explains how the fees system works. Only one charge is required per treatment course of care, regardless of the amount of appointments needed. Nepal. Nepalese population is at a greater disadvantage than westernized societies in terms of oral health. The benefit of implementing health insurance is to assist a large number of people with similar risks by sharing funding. In Nepal, implementing health insurance is difficult due to limited supply of finances. To assist families with accessing health care, elimination of direct payments is necessary but is not sufficient alone. Costs of transportation and loss of income can have more impact than direct payment of services must be considered. Education. The amount of dental professionals produced from tertiary education has increased in Nepal over the years, but remains low in comparison to the rest of the world. There were approximately only 100 dentists in the workforce in the year 2000, which has increased to 240 in the present. Nepal is now using dental hygienists, therapists, and oral health therapists to increase access to dental treatment. Programs such as training rural women about oral health promotion are being utilized to increase awareness of basic dental problems in remote areas. Dental Outreach Program. Attempts to reduce the gap in dental health of Nepalese people through volunteer work provides oral health care education and basic treatment to small villages. Services provided include oral hygiene instruction, distribution of free toothbrush and fluoride toothpaste, application of fluoride gel, application of sealant, screening and charting out treatment plan under a supervising dentist, scaling, filling, extraction, prescribing medicine, and free dispensing distributing medicines. For more information, you can access the Around Good People fact sheet. Early history of dental public health. The earliest known person identified as a dental practitioner dates back to 2600 BC. An Egyptian scribe states that he was the greatest of those who deal with teeth of physicians. 1500 BC Egyptian Ebers papyrus explains oral disease and offers prescription for strengthening teeth and gums. 9th century AD the Arabs discussed the care of teeth rather than extractions and replacement. Mouth hygiene was established with a small wooden stick. Late 1400s the first toothbrush was invented by the Chinese. 1723 a French surgeon describes a comprehensive care system for dentistry including restorative techniques and denture reconstruction. 1791 the first dental treatment available for the poor, established in New York City. 1840 the world's first national dental organization was founded. 1861 Philadelphian Charity Hospital offers dental services. 1865 First ever children's dental clinic, established in Germany. 1867 Boston opened its first low-income dental clinic. 1884 The term oral hygiene come about when M.L. Rhine asks dentists to teach patients how to brush their teeth. 1890 A committee in England carried out oral hygiene promotion in schools. 1989 The powerful slogan "A clean tooth never decays" helps improve standards of mouth hygiene. 1931 Fluoride is identified. 1945 First ever water fluoridation. 1969 World Health Organization, WHO, establishes a data bank which collect information on dental health and needs. 1996 WHO Oral Health Country/Area Profile Program, CAP, is established. This online database presents information on individual countries' oral health services and oral disease rates.
Please subscribe and thanks for watching.